Okay, so this is my reflection journal on my thoughts on manual removal of a placenta. I have not had any personal experience doing this, but I have worked a lot with my preceptor in gaining the skills and understanding the steps to a manual removal. So obviously, like putting on sterile gloves, letting the client know what you're doing, gaining consent, um, following the cord up the vagina and into the uterus, finding the insertion site, kind of cupping your hand and gently removing the placenta from the uterus wall. And then once it's all the way removed, guiding that out, you're going to ensure that the uterus is firm, that the bleeding is minimal, and that, and then like afterwards, everything's done. Making sure that the birthing person is stable, you're going to examine the placenta, not like hours after. You're assessing the birthing person, making sure or the person is stable, and then you're going to examine the placenta rather quickly to ensure that you got all the pieces and that you don't need to enter back in to remove any more pieces. So that's my general understanding and knowledge about a manual removal. As a student, I do have some thoughts. When I'm thinking about things such as the shoulder dystocia, you do have to be fairly, I don't want to use the word aggressive, but fairly strong in inserting your hands and really turning baby. We said before in previous lives, you're not going to turn a baby with one finger and just like doop. You kind of have to be fairly aggressive with your hands and know the maneuvers to get the child out. So with a placenta and removing a placenta, that feels like a very, very different procedure, but I've never physically done it. So some of my questions from a student perspective is, how aggressive do you need to be? Is this like you're really peeling it off type of thing? Or is this really like this gentle scoop, 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 scoop? Okay, I've got it all and we're going to exit type of thing. That was one of my thoughts and questions regarding doing that. Sorry, I just want to check my notes. This is a skill, obviously, I would love to feel more comfortable with, and hopefully a skill that I do get to do before graduation. It's never something, no one ever wants an emergency. No one ever wants to have to deal with an emergency or have someone else go through an emergency. But as a student, it's really beneficial for me to have these skills physically done so that when I am on my own, that I have a good understanding of how to perform these skills. So I would much rather do this under supervision before I am off on my own. And then another thing that I think is not really talked about enough that really should be considered is making sure that the client is going to be okay with this on an emotional level. There are times during a manual removal where there's a postpartum hemorrhage and we need to get the placenta out. And I think that is a very time-sensitive issue. And there's not a lot of time to be worried if the mom isn't emotionally okay with me doing this procedure. And I don't want that to come off as I'm not getting consent, because we always are going to get consent. But it's a life or death situation. So I think that we have to note that and understand that when talking about a manual removal. But if it's not a time-sensitive issue, explaining to the birthing person what we're doing, what we're going to do, what needs to be done. This can be done in the home setting, or we can transfer to the hospital to a higher level of care during this. I'm not familiar with this procedure in a transfer situation, so I don't know once a person gets to the hospital, are they offered pain management before this happens? Do they need to go into the OR and get a D&C? Sometimes that's true, and I have worked with clients that have had to go in to get a D&C done. How quickly does the cervix close up and then the placenta is trapped inside? These are all things to be considered and to be thinking about from a student perspective. But a lot of the research that I looked at and read through really discussed that it's not gonna impact the patient's length in the hospital stay, but that it does impact a postpartum hemorrhage, like the amount of blood, and it does impact possible outcomes of endometriosis. So those are things that should be considered when providing the client with education. And then there was something else I wanted to say in my notes. Sorry. Oh, it's just the emotional piece. Just ensuring that this often is a very painful procedure. So the clients that are at home that don't have pain management, this often is a piece that can be very traumatizing to them. And then you're dealing with trauma, not okay emotionally in the postpartum setting. So know your client. I think it's really beneficial as midwives that we get to spend so much time with our client. If this is a client that has a history of trauma, it might be a recommendation to actually just transfer and not try it at all at home. If this is a client that's like, I want to stay home, like go for it. Maybe that's a client that's kind of a better candidate for this situation. So I think knowing your client is really, really important. And then in Connecticut, experience from my colleagues. So in Connecticut, we don't have licensing. The Department of Health understands that we're here and understands what we do, but there's no licensing and there's no regulations. The midwives have gotten together, but we don't have community guidelines written out for us in the state of Connecticut, which is kind of wild and something I'm hoping that I can change as I grow as a midwife. But from talking with other midwives, our community standards, just from word of mouth, is that if there's a life or death situation, they will try to remove it. If not, they will offer to go into the hospital or they will offer to do it in the home birth setting. And that, one thing that I do know is not all midwives will transfer for this. And some midwives will not automatically offer antibiotics. This will be like a case-by-case situation. From my understanding, I think all clients should be immediately put on antibiotics because you're introducing infection into the uterus, which can become sepsis very quickly and very scary for the client. So all clients should be informed that they need to go on an antibiotic during the postpartum phase. And that clients do have the option to transferring. It's not just does the midwife feel comfortable with it, but is the client going to be okay? And should the client just go in for pain management in order to get the placenta removed? So these are my thoughts about manual removal. I have my outline below, so feel free to read through it.